Our last presenter is Dr. Marc Popovich. He's one of the anesthesia critical care attendings. He's the director of the critical care for the Northern Arc hospitals. Speaking to us today about spontaneous breathing, not just for weaning.
Okay, good morning, everyone. It is a distinct honor and pleasure to be here today to discuss with you this topic. I'm going to expound on why spontaneous breathing is not just for weaning. So I have this list of objectives. I have no disclosures or financial relationships to make. This is a conference speak list of objectives. But let me just tell you the bottom line. A lot of you are probably becoming aware that there's this idea, this concept, this notion that in respiratory failure, breathing spontaneously is not doesn't necessarily reconcile with acute respiratory failure. And so my primary goal today, in the next 15 or so minutes, is to convince you that spontaneous breathing associated with acute respiratory failure actually has value, absolutely has value, and that everything you think you knew about this topic was wrong. Now, and a lot of you are probably saying, "Oh, wait a minute. I don't know about that. This concept is kind of growing, the idea that we should suppress spontaneous respirations, and it's important for acute respiratory failure. In fact, there's literature about this. In fact, some of you may quote me this paper that was published several years ago in the Blue Journal. This is a review article on the topic, and right there in the paper, it says, I don't know if you can see that or not, but it says, there are recent experimental studies, case reports, editorials, and a randomized controlled trial bring into question the safety of spontaneous breathing in patients with severe ALI. Wow. It's not even safe to breathe. Okay. So I guess I have a long way to go to support my case. And so I'm going to start out with asking Mr. Peabody to get Sherman to set the Wayback Machine for 1 million years ago, when over that course of time, when we all acquired this gift of being able to exchange gases and get oxygen into our blood and oxygen to our tissues. How is it possible that this gift, acquired over millions of years of natural selection, all of a sudden is unsafe? Well, we're not here to talk about what's good. We're here to talk about, you're all here because to learn about how to handle things that go wrong. And we all know that, the lungs are the last organ to mature in gestation, so they're probably the first organ to get into trouble whenever patients get sick. So fortunately, human ingenuity over the last 50, 60, or 70 years has resulted in a concept where we can help the lungs using mechanical ventilation. And the first iteration of that is, something known as controlled mechanical ventilation. Controlled mechanical ventilation isn't necessarily reconciled well with spontaneous breathing, as you all know, but in a simplistic form, controlled mechanical ventilation is you breathe only when I say and only how much I say, and that's it. Now, we all know that over the last 40 or 50 years, the evolution of mechanical ventilation has been based on the idea of improving patient-ventilator synchrony, right? Not what I do and what you do, we got to get that to match up. Something must be right about that. And so there's plenty of examples like assist control ventilation in its simplest form is, okay, you can breathe too, but only exactly how much I say. No more, no less. Or intermittent mandatory modes of ventilation, SIMV, and those sorts of things. Okay, you can breathe when you want to, but when I breathe, you can't. I take precedence over you. And it's come down to these bi-level modes, of which APRV is a subset. Okay, now there's a opportunity for independent existence. When I breathe and when you breathe, we can do that independently. Now, I bring this up, I go through this little history for two reasons. The first one is basically just to make sure that it's clear to everyone that most of the research in this topic uses airway pressure release ventilation, APRV. And in case you're not familiar, APRV is you set a high pressure and a low pressure, and the release is the short period of time when the patient is allowed to have the low pressure, but they can breathe spontaneously at any point in that cycle. And in this nice review, it says right there, I don't know if you can see that or not, I probably can't say it, it says the advantages of this mode of spontaneous breathing. The second reason I bring this up is for 50 or 60 years, the concept of mechanical ventilation has evolved to try to work with spontaneous breathing. Is this all no longer true? Should we all just go back to controlled mechanical ventilation and ignore this 50 years? Okay, so what research is there? What evidence out there to support my claim that spontaneous breathing is important? Well, it turns out over the last 15 years or so, the last 20 years or so, there are at least 50 papers on this topic. I only have 15 minutes. I can't go through all of them, but I have a representative sample here that I'm showing you. And that representative sample, the bottom line is, these are patient studies, animal studies, reviews, all that show gas exchange and recruitment are improved with spontaneous breathing. There is a reduction in respiratory muscle atrophy. Diaphragmatic function is preserved. Cardiopulmonary efficiency is improved. And even blood flow to various organ tissue beds is improved when patients are allowed to breathe spontaneously. So how is it possible, with this whole body of literature over the last 15 or 20 years, how is it possible that spontaneous breathing is now considered unsafe? Well, there is an issue in play. And the issue is a principle I need to make sure everyone's on top of before going over the articles that were mentioned in the review article. The issue is, the good thing about spontaneous breathing and respiratory failure is that it improves recruitment. Your lungs, your pleura, your respiratory muscles, your diaphragm all do a better job of recruiting collapsed lung than any positive pressure ventilation. That's the good thing. But the bad thing is, and this is the crux of the argument, what is bad in respiratory failure is worsening transpulmonary pressure. Remember that transpulmonary pressure is the difference between what's inside the alveoli minus what's outside, or the pleural pressure. So if you have too much going in, this is the whole crux of the ARDS, ARDS-net concept, is you have too much going in, that increases the transpulmonary pressure, increases shear forces, and increases injury. But also, you can have too much on the other side of the equation. Too much negative pressure can increase transpulmonary pressure, and that can worsen lung injury due to increasing of shear forces. This is not a new concept. Every day when you manage an asthmatic, that's what's going on with an asthmatic, right? You manage their acute phase, you give them inhalers and bronchodilators, but the secondary phase is because that patient was working so hard to try to generate some tidal volume that the pleural pressure change resulted in this increased transpulmonary effect, increasing shear forces and edema. You give steroids in asthma simply to take care of that secondary effect. This is not a new concept, but it is a critical one to this discussion. Okay, so the review article I mentioned before talked about some studies. Let's just look at those. Here's the first one. Okay, so this research I'm going to show you, the next 3 studies, are all from the same researchers. It's a Japanese lab. These are all excellent, very nice science. I have no argument with the science. I just want to make sure we understand what they're doing. So here's the first experiment. They've took some rabbits, and they subjected the rabbits to 4 different randomized possibilities: low versus moderate tidal volumes, and strong versus weak spontaneous efforts. The spontaneous efforts were adjusted by the type and amount of sedation that the rabbits were given. So the rabbits were given this randomized collection of ventilation, and then it was for a few hours, and then they were examined histologically. And what they found is the rabbits who were subjected to moderate tidal volumes, which is more than would be associated with sort of an ARDS-net type volume and pressure, plus strong and allowed to have strong spontaneous efforts, histologically, their lungs were worse. Okay, it makes sense so far. Here's another experiment. Again, same researchers. Again, they took some more rabbits, and they subjected these rabbits to either mild or severe lung injury based on, they created a laboratory model. And then they allowed the rabbits to breathe spontaneously or not breathe spontaneously, and then examined them under histologic exam. And what they found were the rabbits that were allowed to breathe spontaneously in mild injury led to improved recruitment, but that those in the severe injury led to worsening histologic exam, more airway edema, etc. Here's a study I'm giving you for free. This wasn't even mentioned in the Blue Journal review I said before. This hasn't even been in print yet. This is online only, fresh as today's headlines. From the same researchers, this time they took some pigs and they allowed the pigs to breathe randomly into 4 different ventilator sequences, higher versus lower PEEP, with or without spontaneous breathing. And for this they used a newer concept called electrical impedance tomography, and they identified this concept of the Pendeluft effect. Those of you familiar with the Pendeluft effect is in this use is that areas of lung that have that are inflated, the gas shifts to areas that are not so inflated within the chest cavity without the benefit of an increased tidal volume. Now I have a animation here. Let me see if this will work. I don't know, maybe it'll work, maybe it won't. Anyway, it may kick in here. How long should I wait? 2 guys walked into a bar. Well, anyway, this animation is supposed to show that the blue area shifts from one area to the other without an increase in the tidal volume. That Pendeluft effect leads to increased pleural pressure, worsening transpulmonary pressure, and worsening potentially injury. So what this experiment showed, though, was that the pigs that had higher PEEP had a reduced Pendeluft effect. The theory being that the higher PEEP attenuated the effect on pleural pressure. All right, how do we analyze this so far? Well, how I would analyze this is in a few dozen farm animals, one can make the case that spontaneous breathing increases, opens up collapsed lung to a point. After a point, too much spontaneous breathing actually worsens the situation, leading to an increase in shear forces, increased transpulmonary pressure, which may lead to increase in shear forces, which may lead to worsening lung injury. I have no argument with this so far. Please be aware, though, that the cut point, the break point for this phenomenon, no one knows where that is. And in none of this research was it ever suggested that spontaneous breathing should be interrupted in any way. All right, so they also mentioned a randomized controlled trial. What's the randomized controlled trial? Well, the randomized controlled trial is our old friend, the accurarization systematique, the Accurassist trial. Dr. Esper mentioned this. I'm going to take a little bit of a different take on it here. So this trial is the one you're all familiar with, which is where everyone gets the idea about suppression of spontaneous breathing. In this trial, it's a French trial, they randomized patients to either receive cisatracurium or placebo. The patients that were in the study group received a fixed rate of cisatracurium over 48 hours. All the patients in the study, even in the control group, could get cisatracurium boluses if the researchers thought it was necessary. In fact, over half of the patients in the control group received cisatracurium boluses. And there was an overall, we'll cut right to the chase, there was an overall mortality benefit. It was borderline, but the signal did improve with increasing severity of ARDS. So a PF ratio of around 125 or so, there was a better improvement. The authors of this paper, though, the mechanism, they stated was speculative, but they said the mechanism was maybe improved patient ventilator desynchrony. Patient ventilator synchrony, that's interesting. Nowhere in this paper does it say that we attempted to abolish spontaneous respiration. So, okay, here's my issue with this before I do an analysis. I am saying that this is a high risk, followers of this paper, we are at high risk of history repeating itself. I don't know if I probably need to remind all of you during the course of the 21st century, there have been a multitude of issues that have come and gone as a result, very similar fashion. Those of you may remember that steroids were the be-all and end-all for management of ARDS, the management of septic shock, not so clear. The early goal-directed therapy started out as a very simple concept, very clear, but now it's not so clear. Then there's Zygris. How many of you ever heard of Zygris? Okay, so Zygris, is gone. And then there is the, ground zero for ideas gone wrong, intensive insulin therapy. at its height, intensive insulin therapy was, if you didn't do this, you were a bad doctor, and we're not going to pay you. I'm feeling like history might be at risk for repeating itself. And that is because of all those previous studies were the idea of early adopters, critical care practitioners readily embracing a simple concept when, let's say, skeptics or other researchers attempted to replicate that information, were unable to, or in fact found that some of that information was harmful. So my concern is that we are attempting to do an early adoption of something that is not what it seems to be. So here's my analysis of that randomized controlled trial. The first problem I have is all those studies I just showed you a minute ago, all of them, the control group, how the control group was handled was called into question. And that the control group may have not been subjected to what was considered normal and therefore allowed a signal to develop. I have a similar concern about this paper too. You can go and look at all the quantitative information published in the paper or in the supplemental information. It's all up on the up and up, but I don't know how the patients in the control group were handled. Were they allowed to breathe, have this aggressive spontaneous efforts with strong pleural pressures, and therefore that created a signal? I don't know that. But even without knowing that, nowhere in that paper was the idea of suppression of spontaneous ventilation the goal. Now, this isn't what's happening clinically, though. I don't know what's going on in your ICUs, but what I'm seeing is a severe ARDS and respiratory failure. What happens? Okay, you put them on a neuromuscular blockade, and right away you get out the twitch monitor, and they're on it for days and days and days, and you're titrating to twitches. This is not what was done in the study. And, oh, we're out of cisatracurium. Oh, well, they just put them on vecuronium. Nowhere, this is going 100 miles an hour with a study that really hasn't shown what everybody thinks it has. This concept of paralyzing everyone is counterintuitive with early mobility. This already came up this morning. You're going to create more longer post-recovery times, longer rehab, more critical care polyneuromyopathies. Doesn't match up with the concept of early mobility. Now, some of you might say, well, maybe it's early mobility isn't the right thing. Maybe suppressing spontaneous breathing is the right thing. Well, I would argue that it's not only counterintuitive, but it's counterphysiologic. Suppression of something that has been acquired over millions of years of natural selection is counterphysiologic. And so I ask you, what examples are there in medicine where counterphysiologic principles have been shown to improve patient care? Now, maybe you can think of some. I can't think of any. I can think of some that have gone wrong. Like, for example, bloodletting. We used to bloodlet for centuries. This is entirely counterphysiologic. Only stopped doing it about 80 years ago. Never turned out to be anything. Maybe you don't like this example. Okay, I'll give you one closer to home. How about the concept of supernormal oxygen delivery and consumption? Now, probably only those with a few gray hairs may remember this idea. The idea was that patients who did well, who were survivors, their oxygen delivery and consumption during their acute illness was supernormal. And so the idea was, well, if they did better, maybe everybody would do better if we increased the oxygen delivery and consumption. Again, I don't know about this audience, but I certainly remember running around doing all these calculations and cranking up the dobutamine to higher and higher doses to force supernormal oxygen delivery and consumption. This turned out to be nowhere. What about mechanical ventilation itself? 12 to 15 cc's per kilo. If you went and found a textbook, blew the dust off of a textbook from 1999, it would say in there the initial settings for tidal volume, 12 to 15 cc's per kilo. Indeed, in the original ARDSNet paper itself, the ARMA, what's now known as ARMA paper, indeed it says right in there, the traditional approaches to mechanical ventilation use tidal volumes of 10 to 15 cc's per kilo. We all know this is now harmful. This is counterphysiologic. It is harmful not only in ARDS, but in pretty much every avenue of where mechanical ventilation occurs. So, over 50 papers in the last 10 to 15 years. None of it has been refuted by any of the research that any of the people might think is in existence. I would also point out that one of the farm animal studies that I showed you earlier was accompanied by an editorial. And in that editorial was entitled "To Breathe or Not to Breathe." This is a statement I agree with. From the perspective of ventilator-induced lung injury, the question is not whether to breathe or not to breathe, but rather to breathe the right amount. I completely agree with that. So, in conclusion, spontaneous breathing absolutely has value in the management of acute respiratory failure. And, you know, this picture to me is really two separate thoughts. Let me live, but please, please let me breathe. There is considerable body of supportive evidence unrefuted in the literature. What would be considered anti-literature focused effect of the issue is effect of strong spontaneous efforts and shear forces. I have no problems with this, and the extent of that remains unknown. There are no data supporting the notion that spontaneous breathing in acute respiratory failure should be suppressed. I thank you for your attention today. I have my email address there if anybody wants to email me. In the meantime, I'm happy to take questions. Thank you again.